Case number 1 is a 65-year-old male presenting with palpitations. He has a prior MI and his EF is about 50. The most likely diagnosis is going to be SVT with aberrancy, ventricular tachycardia, artifact, accessory pathway-mediated arrhythmia, or a ventricular paced rhythm. %, think this is VT. All right, case number 2 is a 28-year-old man with palpitations during exercise. Baseline ECG and echo are normal. His EKG during palpitations is coming up. Adenosine bolus terminated the rhythm. The most likely diagnosis for this rhythm, these are going to be your choices: SVT with aberrancy, WPW syndrome, outflow tract arrhythmia, or arrhythmogenic right ventricular cardiomyopathy. All right, so here we go. Case number 3 is a 65-year-old man with prior anterior wall MI presenting with recurrent VT and syncope. His EF is 40. His most recent ischemia evaluation was negative. He has an ICD in place for secondary prevention purposes. The next step in his care would be to add mexiletine, flecainide, propafenone, or sotalol. Okay, Siva, teach us what we need to know about ventricular arrhythmias without an esophageal lead.
Thank you, Steve. It's a pleasure to be here talking at the board review course this year. I have 3 learning objectives, and we will spend a lot of time on the first learning objective, distinguishing SVT from VT on a wide complex strip. So the ECG leads, the position, gives us an important clue to the electrical activation of the heart. So the chest leads, V1 to V6, are precordial leads, and they're looking at the heart from an anterior aspect. Leads 1, AVL, and partly V6 give you information looking from the left side of the heart. On the other hand, V1 and AVR give you electrical information looking from the right side of the heart. So the right and the left-sided leads kind of give you mirror information. What does that mean? If you have a predominantly positive QRS in the left-sided leads, you can expect a predominantly negative QRS in the right-sided leads. And the inferior leads give you information looking from the bottom of the heart. So once you have a wide complex rhythm, when the QRS is more than 120 milliseconds, the first step we look at is lead V1. Remember that lead V1 is placed anteriorly, and if that activation is going away, or if the QRS is predominantly negative, we call it as left bundle morphology. This is not the same as left bundle aberrancy. We're just referring to the QRS as left bundle morphology. If it is predominantly positive in V1, the activation is from posterior to anterior, we refer to as right bundle morphology. Now, it's good to review the physiology of normal activation. As the electrical activation passes through the AV node, it goes through the bundle of His and then through both the bundle branches. So the proximal part of the conduction system, the His bundle and the bundle branches are both insulated. So the electrical activation starts relatively more towards the apex of the heart, So the activation is apical to basal, and it is endocardial to epicardial. The left bundle is a thicker structure and a faster conducting structure. Because of that, the septum is going to be activated from left to right. And due to that activation, when you pay attention to a normal ECG, you see these small Q waves in the left-sided leads. We refer to them as septal Q waves. Anytime you have an anomalous activation, meaning if you have a left bundle branch block, now the septum gets activated from right to left. And you should not see any Q waves in that if the rhythm was SVT with aberrancy. And we'll dwell more into that concept as we progress. So what are the causes of wide QRS rhythms? So the narrow QRS is due to simultaneous activation of both the ventricles. If you have an extra pathway which bypasses the normal conduction system, you see a short PR interval and a delta wave. That delta wave is due to slow myocardial activation near the pathway. The second common reason is SVT with aberrancy. When one of the bundle branches is blocked, now the ventricles are activated sequentially. One gets activated first, transeptal conduction, and the other one gets activated later. So in general, if you have a right bundle branch block with a QRS duration less than 140 or a left bundle less than 160, more likely to be SVT. Now with pacing and ventricular tachycardia, the simultaneous activation is also altered. Now they're activated sequentially, and you can have a wide QRS. The last and important testable item on the boards is recognition of artifact. So in this particular tracing, when you look at it, when you glance at it, you have a wide complex rhythm. But if you pay close attention, there are these signals that kind of consistently march through the tracing. So when you see this, it is artifact, and it is very important not to do any interventions that can harm this particular patient. So in clinical practice, you can recognize WPW looking at the baseline rhythm. Paced rhythm, you'll see pacing spikes. Artifacts, if you pay close attention, you'll be able to pick it up. The two main things that boil down are SVT with aberrancy and ventricular tachycardia. So how do we distinguish those two? So if the V is faster than the A, it is most likely ventricular tachycardia, and this is the most specific of all the criteria that are out there. Sometimes when you have an atrial activation that's able to conduct down and cause a QRS that is narrow, we refer to this as capture beats. Occasionally, this supraventricular impulse can cause a fusion beat, which is intermediate morphology. Both capture and fusion beats denote that there is VA dissociation. Now let's have a look at this tracing. First, the QRS is wide, at least more than 3 small boxes. And in lead V1, it is predominantly positive. So we say this is right bundle morphology. But when we pay close attention to the rhythm strip, we have these extra blips that are not there with every QRS complex. These small blips are the atrial activation. So when the A is, you see fewer A's than V's, then it's VT. Now this particular beat is narrow, looks like sinus, that's a capture beat. And when you have an intermediate morphology like this beat, it does not look like VT, does not look like the sinus beat. This is the fusion beat. Now, the rest of the principles all look at non-physiological ventricular activation. So it's very unusual to have a northwest axis with supraventricular rhythm. You can have right or left axis deviation due to either pressure or volume changes or hemiblocks, but it's unlikely to have a northwest axis. Fortunately, we have a lead AVR, looking at the northwest quadrant. So if you have a predominantly positive QRS in lead AVR, it is VT. Now, the next principle that we'll look at is the precordial transition. Because of the apical activation, there is a transition, change in polarity in the precordial leads. When you lack that change in polarity, either positive concordance or negative concordance, it means that the rhythm is VT. So positive concordance means that the rhythm is arising more basally. Negative concordance means that the rhythm is arising more apically. Now, the last part is looking at the initial and terminal slopes. So how do we look at this? If you take a QRS, you take the first 40 milliseconds of the QRS and the last 40 milliseconds of the QRS and see how far vertically the QRS travels in that 40 milliseconds. In VT, the initial slope is going to be slow and the terminal slope is going to be fast. The initial slope is because of the slow cell-to-cell activation, whereas the fast slope is because of the engagement of the His-Purkinje system. It's opposite to SVT. Even if one of the bundle branches is blocked, the other bundle branch still conducts. So the initial part is going to be fast and the terminal part is going to be slow. So there are two main algorithms for differentiation between SVT and VT. And if you put all these principles together, those are the steps in the algorithm. So we start out with VA dissociation. This is the part in the Brugada criteria. The second thing is the activation patterns. So we said that with right bundle branch block, your septum is still activated from left to right. So it is unusual to see Q waves in the right-sided leads. And you'll have a mirror image R waves in the left-sided leads. Now with left bundle branch block, now the septum is activated from right to left. It is unusual to see Q waves in the left-sided leads and R waves in right-sided leads for a supraventricular conducted rhythm. Now the third thing that we look at is the axis. If you have that northwest axis or a positive QRS in lead AVR, it is VT. We said precordial transition, absence of RS complexes in the Brugada criteria. Lastly, we sum up by looking at initial versus terminal slopes. Now, you can imagine that we already have two algorithms. What is the need for a newer algorithm to distinguish SVT versus VT? So the Brugada and the AVR criteria were developed in predefined sets, like patients who were on antiarrhythmic drugs were excluded, patients who had electrolyte abnormalities were excluded. Even though in those subset pre-selected ECG, they were doing very well, when you use them for all comers, they were not performing well. So colleagues have published a new scoring system which incorporates all the steps with this thing called VT score. So if you have 3 or more points on the VT score, it is 99.6 specific for VT. 4 or more is 100%. So this is the new kid on the block, the VT score. Now, once you have the tracing, you should always put this in clinical context. When somebody gives you a tracing for wide complex arrhythmia, there is a 80% pretest probability that it's going to be VT. Now, if you have history of myocardial infarction or heart failure, that pretest probability increases to 90%. And there are certain things that are not helpful in distinguishing between SVT and VT. One is rate. In general, we think that if the rate is faster, it can be SVT. Now, the rate depends on the size of the circuit. If the circuit size is small, you tend to have faster tachycardia. Now, hemodynamic stability. Now, there is a fallacy that SVT is going to be hemodynamically stable and VT is going to be unstable. It's not always true. The hemodynamic stability depends on the rate, LV function, on autonomic tone at the time of the arrhythmia. Now, when in doubt, try not to use long-acting agents. Using a drug like verapamil, when you're not sure, can cause hemodynamic instability and can convert a stable situation into an unstable situation. So once you know what it is, If the patient is unresponsive, CPR, follow your ACLS algorithms. If the patient has signs of end organ perfusion, then you look whether it is organized or disorganized rhythm. Organized rhythm, perform a synchronized cardioversion. Disorganized rhythm, try to do defibrillation, nothing to synchronize there. One particular situation you want to think about is electrolyte abnormalities. If the patient has pre-existing electrolyte abnormalities or predisposition, there's no harm in giving them like 2 grams of magnesium. Now, if you have a stable arrhythmia, like the one that Steve has shown you on an esophageal ECG, you look at your differential diagnosis. If it turns out to be SVT, start out with vagal maneuvers. Adenosine is a quick drug that it is both diagnostic as well as therapeutic for SVT. Now, if tachycardia keeps on recurring, you can consider calcium channel blockers or beta blockers. Now, procainamide is something that can be tested on the board. If you have a baseline delta wave, patient has atrial fibrillation, wide QRS, varying widths of the QRS, that tells you AFib in a patient with WPW. Procainamide is a drug of choice in that patient. With VT, you can give IV bolus of amiodarone or perform a cardioversion. Now let's move on to the next learning objective. Once you have mastered the SVT versus VT, the rest of the topics that we're going to talk are going to be like a cakewalk. So we will look at different etiologies of ventricular arrhythmias over the next 10 to 15 minutes. So idiopathic VT is a VT occurring in the setting of structurally normal hearts. What do we mean by structurally normal hearts? In the absence of coronary artery disease, preserved ejection fraction, or absence of scar. Idiopathic VT most likely comes from outflow tracts, papillary muscles, or around the perivenous areas, like here, confluence of the coronary arteries and veins. Now, the ECG that's likely to be tested on the boards is one that it's paroxysmal, patient presents with palpitations. You can see you have wide complex beads. It's negative in V1, so left bundle morphology, and it's inferiorly directed, so positive in the QRS. In fact, when you look at the QRS in the inferior leads, the QRS is taller compared to the sinus beads, which tells you that the focus is at a higher level than the sinus exit. So this is a VT coming from right ventricular outflow tract. So happens most commonly in structurally normal hearts. It's rarely associated with sudden death. If you are treating these patients, it's mainly for symptoms. And there seems to be difference in triggers for these arrhythmias. In men, it's mostly catecholamine or exercise related, whereas women, there is a hormonal relationship that has been described. And there are some patients who do not feel these high burden of PVCs. So in the guidelines, 10% or more, when you have high burden of PVCs, there is an increased risk for dilated or non-ischemic cardiomyopathy with the high burden of PVCs. Now, what causes idiopathic VT? So the idiopathic VT is because of the calcium overload. Here is an action potential. We are pacing the ventricle. You have an action potential. And with each beat, you have some oscillations in the membrane potential. This is because of calcium overload in the cells. We refer them as triggered activity, and they're occurring in the latter part of the action potential, delayed. As we increase the rate, the oscillations also increase, and sometimes when they reach the resting or the threshold potential, they can start off a QRS or a new action potential. And this is the reason why they are catecholamine or exercise dependent. So how do we treat these arrhythmias? So calcium channel blockers or beta blockers, both of them reduce these calcium oscillations. Now, adenosine is a drug that works via the cyclic AMP pathway. It lowers that calcium overload. So if you give it to a patient with RVOT-VT, that can also terminate the arrhythmia. So adenosine is not just specific for AV node, it can also terminate RVOT-related triggered activity arrhythmias. Compare that with papillary muscle VT. The mechanism is slightly different. In papillary muscle VT, you can see the slope, the phase 4 during diastole, the phase 4 slope, it almost gets like a pacemaker-like activity. It slowly reaches up and reaches the threshold potential, starting off a new QRS. So the mechanism is different for papillary muscle VT. Another ECG that's likely to be tested on the boards is this particular one in a young patient, exercise-dependent, complaints of palpitations. When you look at this, it's relatively narrow. And the QRS is wide in lead V1. So it is right bundle morphology. And it is negative in the inferior lead, so left axis deviation. So structurally normal heart, right bundle with left axis deviation is fascicular VT. So what happens in fascicular VT? There seems to be a slow zone in the septum where you go down the slow zone, come up the normal conduction system. The mechanism here is re-entry. And verapamil is one particular drug that seems to even slow down this conduction in the slow zone, thereby terminating the arrhythmia. Now, adenosine is going to be insensitive for this particular arrhythmia. Majority of the arrhythmias that you are going to see in clinical practice in somebody with structural heart disease are because of re-entry. Now, this is an autopsy specimen of a patient who had anterior wall MI. As you can see, the volume in the anterior wall is decreased, and you see a thick scar. And in the region of wall motion abnormalities, these patients tend to develop thrombi. Now, not all scar is dead. When we do histopathology section of what seem to be like scar, there are areas of surviving myocardium. We sometimes refer to them as mummified myocardium inside the scar. Now, these surviving cells can slowly conduct and re-excite the heart, resulting in re-entry. So if you look at the video or animation picture, inside the scar, there are areas of slow conduction. And if you put up catheters inside the heart, you can see certain areas of scar are activated very late, like this area activated on time with the next QRS. Now, if a slowly conducting impulse were able to come out and re-excite the heart, we set up a circuitous arrhythmia re-entry. It's a re-entry ventricular tachycardia, and this is the most common mechanism in somebody who has structural heart disease. Now, ARVD is something that you are likely to be tested about on the boards. Now, this is a cell-to-cell adhesion problem. When that gap junctions are abnormal, the myocardial cells are replaced by fat, and this predominantly affects the right ventricle. There is a diagnostic criteria. The desmosomal proteins are abnormal in patients with ARVD. And these patients, because the right ventricle is involved, they have a left bundle morphology arrhythmias. And one key point to remember for the boards is exercise in patients with ARVD accelerates progression, and you should counsel patients against endurance sports. Now, this is a ECG in a patient with ARVD. When you pay close attention to the precordial leads, V1 to V3, the T waves are inverted. So it's never normal to see inverted T waves in V1 to V3 in adult patients. It's normal in juvenile patients, but not in adult patients. Not only that, you have depolarization abnormalities. So you see how the QRS is kind of squiggly towards the end? So those are areas of slow conduction. So depolarization, repolarization abnormalities of the RV. Think about ARVD for the boards. So then another disease that can be tested is sarcoid. So somebody who has non-ischemic cardiomyopathy, heart block, think about sarcoid. So consider doing an FDG PET scan to diagnose sarcoid, have a low index of suspicion. Now sometimes we do electroanatomic mapping to take biopsy in the areas where there are abnormal electrical signals. That can increase the yield of your biopsy. So another ECG pattern that can be tested on the boards is bundle branch reentry. This is an arrhythmia in non-ischemic dilated patients where you have a slowly conducting bundle that can come down and go up the other bundle. So how does it look on an ECG? Here's an ECG in sinus rhythm. The VT looks very similar like the sinus rhythm, except that you have VA dissociation. So buzzwords, non-ischemic cardiomyopathy, syncope, wide complex rhythm that looks like sinus rhythm, think about bundle branch reentry. Now, moving on from monomorphic to polymorphic VT, as you can see, the normal action potential correlates with what we see on surface ECG. And as you have action potential duration increase, the QT interval is prolonged. When it is beyond a particular number, you tend to have oscillation of the membrane potential, which can reach the threshold and cause an arrhythmia. We refer to this as early after depolarizations. Now here is an ECG. The patient is in some sort of idioventricular rhythm. You see there is no P wave, wide QRS. The QT is quite long, and you have these additional QRS complexes which look like bigeminy. These are mostly EADs, a single EAD that reached a threshold, and as there is variation in the QT interval, you have two EADs there that results in a longer pause. Now you have another EAD that sets up polymorphic VT. So once you see polymorphic VT, think about underlying causes. If it is ischemia, fix the ischemia. If it is due to electrolyte abnormalities, stabilize that membrane irritability with magnesium. Look for genetic abnormalities. If everything is corrected, patient still has long QT. Now putting it all together, idiopathic VT is commonly seen in patients with structurally normal heart. You treat these patients only if they have symptoms or if they develop tachycardia-induced cardiomyopathy. The mechanism there is delayed after depolarization and calcium overload. Fascicular VT, right bundle, left axis deviation. So it's going to be relatively narrow. Verapamil tends to terminate the arrhythmia. Scar-based VT, the mechanism there is re-entry. And remember bundle branch re-entry. Somebody with syncope, non-ischemic cardiomyopathy, the wide complex look like sinus rhythm. Now polymorphic VT, think about early after depolarization, electrolyte changes, and underlying ischemia. Now let's look at the last learning objective and how to select management options when patients have these ventricular arrhythmias. So idiopathic VT, the drugs of choice are calcium channel blockers, beta blockers. Rarely you can come across patients who are on antiarrhythmic drugs. Acutely, adenosine again reduces that calcium overload and terminates the arrhythmia. Ablation is preferred just because the outcomes are a lot better. In younger patients, you don't want to put them on medication long term. But again, it's a decision-making process where you have a discussion with the patient. The key concept here that is going to be tested on the boards is no ICDs for these patients. ICDs are contraindicated in somebody who has idiopathic VT, just because the death rate is so slow and we have better ways of treating these arrhythmias. Now, once you have scar-based VT, it's the potassium channel blockers, the class 3 agents, amiodarone, sotalol, and dofetilide. A lot of these patients get defibrillators based on primary prevention indication, or if they have suffered an event, secondary prevention indication. If they have recurrent arrhythmias after a defibrillator implant, you give antiarrhythmic drugs or consider an ablation procedure so you can modify the scar and eliminate those areas of slow conduction. In advanced structural heart disease, you may consider modifying the neural input to reduce the frequency of defibrillator shocks in these patients. Now, bundle branch reentry is one arrhythmia where you should consider a ICD. Patient has structural heart disease, and if they have a recurrent arrhythmia, ablate one of the bundles. So there is that circuit that supports reentry is taken care of. Now, once you have polymorphic VT, consider magnesium at 2 to 4 gram. It stabilizes the membrane potential and prevents that early after depolarization. You try to pace so you can shorten the QT interval, and that also reduces the frequency of EADs. Avoid all medications, especially in somebody on a lot of medications in the hospital. Look at that list of medications that can prolong the QT interval. You can consider using isopril and dopamine to increase the heart rate before you can actually place in a pacing wire to increase the heart rate. And again, the underlying causes. To summarize, for the boards, SVT and VT is most likely going to be tested. And remember that VA dissociation is specific for ventricular arrhythmias. If you cannot identify ventricular VA dissociation, look for signs of non-physiological activation of the QRS. And once you have an idea of SVT versus VT, always put it in clinical context. If they say clinical heart failure or history of MI, they're most likely testing you on ventricular arrhythmias. Now, idiopathic VT, very low risk of sudden death, and drugs, consider ablation. Again, no ICDs in this patient. That is a testable topic. Now, once you have scar-based VT, potassium channel blockers, defibrillators, and again, ablations to improve quality of life, and in advanced heart failure patients, consider neuraxial modulation. And do not forget artifact. In fact, if you look at the study that was published in NEJM, a significant proportion of cardiologists and even electrophysiologists were not able to recognize the artifact. So if you have a marching signal inside a white complex strip, think about artifact. No interventions for that patient, and likely answer is going to be reassurance. So I have put together a few guidelines for you to look. You have to look at the class 1 and the class 3 indications. That's where most of the questions are going to be based on. And again, a few journal articles on the VT versus SVT algorithms. The first one is the Brugada criteria. The second one is the AVR criteria. And the third one is the VT score, the newer kid on the block for distinguishing SVT versus VT. I think I'll stop there, and let Steve do the questions.
All right, Jimmy, over here. Okay, we are on a tachyarrhythmia pace for the EP day. We're ahead of schedule. This is great. So, let's go over these cases. First one is a 65-year-old male presenting with palpitations. He has a prior MI and an EF of 50. We're going to be asked what the most likely diagnosis is, so if we just go to the next slide, it'll show the ECG. So I'll review the history again. 65-year-old prior MRI, EF 50. Click forward to give them their choices again. Go ahead and key those in.
That's great.
Nice.
Can I go over a few points?
Yeah,
of
you
that?
can go over a few points, yeah.
So I think when you look at the tracing, take your time and start off with the rhythm strip and see if you have some unusual deflections that are not present with every QRS. See this guy here, this guy here, this guy here. So those are P waves. Once you have VA dissociation, it has to be VT. And if you cannot identify VA dissociation, then the next step is to look at non-physiological activation. So look at lead AVR. So it's predominantly positive, right? So the axis is more towards AVR. That has to be VT. And lead V1, when you line up the beginning of the QRS, see how the first 40 milliseconds is so slow when compared to the last 40 milliseconds. All these clues, they guide you towards VT. And in the stem, even before you look at the tracing, they're giving you a wide complex rhythm, MI, your pre-test likelihood is going to be 90% that it's going to be VT.
Thank you. Case number 2 is a 28-year-old man presenting with palpitations during exercise. His resting ECG and echo are normal. We'll show his palpitation-causing ECG in the next slide. And adenosine bolus stopped this rhythm. So the most likely diagnosis is going to be SVT with aberrancy, WPW, an outflow tract tachycardia, or ARVC.
I think this is a question where we had a big spread in the beginning.
I think so, yeah. And still a bit of a spread.
Yeah, yeah. So let's look at this tracing closely. Okay, so when you look at this rhythm strip, so again, so wide complex rhythm, it's predominantly negative in lead V1. So it is left bundle morphology. So in the stem, they're giving you structurally normal heart, somebody who is young, normal ECG, normal echocardiogram. Okay, so things that are pointing more towards idiopathic arrhythmias. So when you look at this rhythm strip, these extra deflections, this one here, are not there in every QRS. Now, if we had given you the time and if you looked at it more closely, more likely if you have got, you would have been able to pick this up. Now, this is RVOT-VT. Now, remember, RVOT-VT is because of the calcium overload. And adenosine can prevent that calcium overload and terminate the arrhythmia. So adenosine is not specific for SVT.
So how is that person going to be managed? So they have an outflow tract tachycardia. Is that an easy ablation case? Is that going to be a drug case? How are you going to approach this guy?
I would say it's again a shared decision making. In somebody who does not want to take drugs long term, we can offer ablation. But again, they are quite responsive to beta blockers and calcium channel blockers. You can try them, and if they fail the drug, go to ablation next step.
Okay. All right, case number 3 is a 65-year-old male with a prior anterior wall MI, presenting with recurrent VT and syncope. His EF is 40. He has an ICD in place already. And the question is, which antiarrhythmic drug do you want to start? Mexiletine, flecainide, propafenone, or sotalol? %, say sotalol.
Okay, that is the right answer, I think. So if you look at the stem, patient has structural heart disease. Somebody who has a prior MI, has a defibrillator. The sodium channel blockers, like the 1C drugs, like flecainide, propafenone, are pro-arrhythmogenic in those patients. The slow conduction, make arrhythmia last longer. So you do not want to use them in somebody who has structural heart disease. Mexiletine by itself is not effective for ventricular arrhythmias. So if you have an arrhythmia in structural heart disease, think about potassium channel blockers.
Right. So I want to ask you a couple of questions about not sustained arrhythmias, but frequent PVCs and symptomatic PVCs, when they cause heart failure, how you treat them when they're symptomatic, those kind of things. Can you just tell us a little bit about that?
So if the patient has symptoms, first step is to correlate with their arrhythmias. If they have a good correlation on Holter or event monitoring, it's reasonable to pursue rhythm control, eliminate those PVCs or those arrhythmias. So then the next bifurcation is, does the patient have structural heart disease or not? So if the patient has structural heart disease, again, potassium channel blockers. If no structural heart disease, is most likely going to be idiopathic VT. Again, medications versus ablations in those patients. There are a small portion who have high burden, more than 10%. Some studies say 20% burden of PVCs, but no symptoms. Their presenting symptom could be the first episode of heart failure, tachy-induced cardiomyopathy. So in those patients, either ablation or using medications to see a short period of rhythm control would improve their EF would be the way to go.
But so it takes a lot of PVCs, though. 10 to 20% of their daily heart rates are ectopic beats.
That's right. Most of the evidence is pointing towards 20 or more percent. Although there are some studies that say 10% can increase the risk. So what that means is we have about 100,000 beats in a day. So if you have trigeminy or quadrigeminy, that's when you should consider thinking about tachy-induced cardiomyopathy. So even if they don't have any symptoms, yearly echo to see if their EF is dropping may not be unreasonable in those patients.
So Dr. Mulpru put together a chalk talk to kind of go through that SVT, VT stuff again. It is online already. It's underneath his lecture under Chalk Talk, but I think it's reasonable to review it here again just because this is such a testable component for the boards and something that we have to face kind of relatively quickly in real life. And so let's look at his Chalk Talk on SVT versus VT.
A tracing with wide complex tachycardia presents an important dilemma for physicians. The two main differential diagnoses are ventricular tachycardia and supraventricular tachycardia with aberrancy. Fortunately, understanding the position of the ECG leads and normal physiology can tease them apart. Chest leads are precordial leads. Leads V1 and AVR image from the right, while 1, V6, and AVL provide information from the left. Based on lead V1, we refer to the QRS as left bundle or right bundle morphology. Depolarization is from apex to base, and the septal activation is from left to right. This leads to tiny Q waves in leads 1 and AVL. There are three main algorithms for differentiation, and the underlying principles are the same. The combination of above features in all the leads, VT score. Let's look at the principles to differentiate VT and SVT. When V is faster and independent of the A, the WCT is most likely VT. Presence of capture, similar to sinus beats or fusion, intermediate morphology between sinus and WCT, also suggest VA dissociation. The rest of the principles look at non-physiological ventricular activation. It is unusual to have northwest axis with SVT. Among precordial leads, there is a transition, change in polarity, from V1 to V6. Lack of that change, positive or negative concordance, suggests VT. VT has slow initial slope and fast terminal slope, as initial QRS is inscribed by slow myocardial cells, while fast terminal QRS is due to engagement of His-Purkinje system. With right bundle branch block aberrancy, septum is still activated from left to right. Activation is reversed from right to left with left bundle branch block aberrancy. ECG signs of non-physiological activation suggest VT. Combining all the above principles is the essence of the two main algorithms. The VT score combines features of all the algorithms.
That is it.
So all you have to do is memorize that. And if you can say it just slightly faster than that, then you win. So Siva, thanks so much for putting that together. I appreciate your review.
Thank you very much.
Yeah.